All right. All right. And Alex, just let me know when the attendees stop trickling in. And then Crystal will put in the link.
It's a good time to get started, please.
Okay. I'll wait and I'll wait for Crystal to put the link in. All right. Good afternoon. Welcome back to our 2024 webinar series with the New York Association on Independent Living, or NIAL, NYAIL. I am the communications specialist, Blaze Bryant. Again, thank you so much for joining us for what should be a very interesting presentation about how to implement overdose strategies or I should say overdose prevention strategies and harm reduction strategies from Jessica Sorbello with the Office of Addiction Services and Supports, OASAS. And before I turn things over to Jessica, I have a few housekeeping things. Number one is the webinar will be recorded and made available afterward. Number two, the chat is disabled for the attendees. Although if you need to get in touch with any of us panelists, you should be able to. This is for screen reader accessibility accommodations. So to ask any questions, or if you are having any tech issues or whatsoever, please use the Q&A box that is on your screen. The last thing, and I will mention this again at the end, is there is a survey for gathering your thoughts and ideas on future webinar topics, because, hey, we're all here because we want to make the world a better place for people with disabilities. And one of the ways we do that is through education and awareness. So without any further ado, Jessica Sorbello, the floor is yours.
Great, thank you so much. Hi, everyone. My name is Jess Sorbello. My pronouns are she, her, hers, and I am excited to be here with everybody. And so my presentation typically is about 2 hours long. I do ask that if anyone has questions, anything doesn't quite make sense, and I'm hoping this is possible for folks to unmute themselves, but please unmute, jump in, and interrupt me, because this training truly works a lot better when it's a conversation and when we have the ability to address concerns and questions and sometimes even client cases in real time. So truly don't hesitate. I joke on most of these that I have never gotten through all of my slides, and that's a great thing, because it's largely due to the interest and the facts that everybody wants to do things a little bit differently. And harm reduction as a concept is something that is new, and kind of continuing to evolve. So again, please just unmute, jump in, and happy to kind of pause and visit any questions or concerns that you have.
Okay,
and then
Jess, before you,
yeah.
before you continue, panelists should have the ability to raise their hand, and
Okay.
that will be the cue for us to unmute you if you would like to participate. And if not, we will get that squared away.
Okay, great. Thank you so much. And Blaze, is somebody able to kind of monitor that? Just because I can't necessarily see with the screen share.
Yep. Alex and myself, we
Okay.
both have you.
Perfect. Thank you. All right. So that being said, we will get started. So, again, as Blaze said, the overall concept of this training is really on understanding substance use, and learning concrete skills to be able to implement harm reduction strategies and overdose prevention strategies, within, the workplace. So I am here with OASAS, so again, the Office of Addiction Services and Supports, but specifically I oversee Project COPE, or Community Overdose Prevention Education. And this is a 5-year grant that is funded through SAMHSA and really focuses on increasing availability and awareness of overdose prevention education and resources into the community. So, again, because we are funded, through SAMHSA, please note that, none of my views are necessarily fully, supported by SAMHSA, although so far so good. All right, so training objectives. I'm just going to kind of fly through these first few slides. Just again, let's get to the stuff that everybody came here for. And so to start off, I do want to say just kind of a couple things. So I do talk very candidly about substance use and overdose. And so, I just say that as a bit of a warning, because everybody has their own situations, their own stories and experiences. And I just want to be mindful of that, but also recognizing that it's an important topic for all of us to be comfortable discussing. And the other piece is the goal of this training is not to make anyone substance use treatment experts. I recognize that everybody here has their own scope of work and scope of practice. And, I have spent over a decade working, in the front lines of direct care and recognize that everybody's plates are full. And I like to say up front that, again, the goal is not to be treatment experts, because I do recognize that going into another training and feeling like you have to add, another 20 hours of work to your weekly schedule, kind of causes that, understandably, that kind of sense of shutting down a bit. And I don't want that to happen. So the goal is just really to increase awareness and understanding and empower all of you to just be able to kind of supplement the work that you're already doing. So through psychosocials and assessments and similar concepts like that, we want to just be able to comfortably discuss substance use, right? Again, not in a way to expect anyone to be able to treat it, or work directly with those clients in long-term situations. But the same way that, someone who's working with you shares their medical history and their family history and their legal history, substance use is a big component of understanding the whole person. And I know through my time of working, in direct client care, that if I wasn't comfortable with a topic or a conversation, I would try my best, but ultimately stumble through it. And our clients are very smart. They can read all of us probably better than any of us can read anyone else that we work with. And so what would happen is, that client would kind of shut down, because they're feeling like, I don't know what I'm talking about, or I'm judging them, or, something along those lines. And even though judgment is not what's happening, it's often what's conveyed through our own discomfort. So again, we do this to be able to talk about it so that we can all have these conversations in an anti-stigmatizing and really, comfortable way. And again, recognizing that each and every one of us comes into our job with our own bias, our own judgments, and our own experiences. And, no one is bad for having, bias, right? We all have it. The problem only exists when we refuse to acknowledge it, and refuse to try new things to work through it. So just kind of please keep that in mind, through all of this. And that, again, this is just, information and skills to further enhance the work that you're all doing. So we start off by looking at, the data that shows really why we're here for this conversation, and that is the overdose rates, both nationally and throughout New York State. So in 2021, nearly 107 people died of an overdose, which comes out in New York State to be 6,037 people in total, again, during the year 2021. Which nationally is 292 people a day, and that's 16 people every day in New York State. And we really want to keep in mind that when we say people, we mean parents, children, loved ones, community members. I think we've really seen time and time again that, overdose does not discriminate. And that is because of fentanyl, which we will discuss in just a few slides, but keeping in mind again that no one is immune from that risk, which again is why we're here. So when we look at those numbers, we know that 16 people a day is shocking and really hard to comprehend. But it starts to look even worse when we compare it to just 2 years prior. So in 2019. And specifically, actually 2018. In 2018, there was 40,000 people that died annually from an overdose. In 2018, 40,000 people died nationally, not annually, by overdose. And so again, when we look at 2021, that number being nearly 107,000. So that is more than double in just 3 years. Now, we do know the pandemic certainly played a part in that, but it's not the only factor. And that's where we really want to kind of look at the presence of fentanyl and what that means. And so fentanyl is a synthetic opioid that is laced in nearly all illicit substances. So what's really important to recognize is, when we talk about substances, we look at them as value neutral, right? Fentanyl is not bad. Fentanyl serves a purpose. For anybody who has gone through, major surgery or a significant hospital stay, fentanyl was incredibly important in that recovery process, right? It manages pain. So it's really keeping in mind that the purpose of these conversations is not to villainize any substances, right? It's looking at how they are used, and that is what makes something problematic. Again, in 2021, so when we look at that, 107,000 deaths, 75% of overdose deaths in New York State involved synthetic opioids like fentanyl or its analogs. So what that means is, fentanyl is being laced in nearly all substances. Again, fentanyl is an opiate like heroin and pain pills, but you need an incredibly small amount, really just the tip of a pin to get the, an increased and even worse effect than, morphine. So, fentanyl is being laced in substances for several reasons. It really intensifies the high, it makes it much more potent. It's also because of that, potency, it's much cheaper, right? So something that's kind of uncomfortable, but we have to look at is the fact that, drug dealers are running a business, right? So, again, that feels uncomfortable to say, but when we want to really understand why this is happening, it's important to look at. A small amount of fentanyl and then mixed with other non-illicit substances is incredibly cheap to make. But that means it's also increasing its potency, which is increasing the death risk. And it's not just heroin that's being laced. And again, that's really why these conversations are so important, because, for a very long time, overdose was something that we equated with folks who used chronically, right? So somebody who is consistently using heroin or prescription pain medications. And since the presence of fentanyl in all of these substances, it's folks that are using occasionally, possibly even once, that are at risk of overdose. when we look at this occasional use, it's also folks that don't even meet a criteria for a substance use diagnosis, right? So somebody who does a couple lines of cocaine every few months, they're not going to meet criteria for a they're not going to meet diagnostic criteria. And they're certainly not going to, meet the need or even identify a need for a substance use treatment program, right? So, when I started this project, I really started to kind of look at, okay, in these past few years, treatment programs are doing a great job of getting naloxone out to, all of the patients. Wonderful. But the number of overdose deaths is still rising, which means something is missing. And so we've really started to look at, this kind of middle group that uses occasionally, doesn't get substance use treatment because, again, they don't necessarily need it. And therefore, they're not considering themselves at risk for an overdose. And, therefore, they're not getting the test strips or the naloxone or all of that information. And, they're what we would call opiate naive, many of them. So somebody, again, who uses cocaine or other stimulants on an occasional basis has no tolerance for opiates at all. And so again, therefore, their risk is even higher. And so we look at cocaine, amphetamines, and we also look at counterfeit or pre-pressed pills. So the example that I use a lot when discussing this is, really recognizing that many folks take a pill with the best of intentions, right? Not everybody who takes something is looking to misuse. And I mean, truly, it doesn't matter the motive of why somebody uses, right? It is still our role as human service workers to be able to do everything we can to save lives. But really understanding that unless a pill comes directly from the pharmacy, you have no control and no guarantee over what's in it. So one of the examples is, let's say I am diagnosed with, an anxiety disorder and I suffer from severe panic attacks. My doctor has prescribed me Xanax. I take it, as a PRN, right? So just as needed. And I am out someplace with a group of friends and I realize that I didn't bring my Xanax and I am starting to have a panic attack out in the community. Right? Somebody that I'm with says, oh, don't worry, I've got some with me and hands me one, right? Where again, the intention is purely just to take the medication I'm prescribed, I just don't have mine. But if that individual didn't get them directly from a pharmacy, which is very common, the likelihood of that Xanax being laced with fentanyl is incredibly high, right? So this is where we start to really kind of recognize what it means when folks say, everyone is at risk, right? And for many of you, you may be the only consistent providers and, home workers and health aides that some of these folks are working with, right? And, being able to build that rapport and have these conversations is incredibly important because, again, that risk is so high and so many folks don't recognize that.
We did have one question.
Yeah, absolutely.
Laura's asking for the number of total overdoses, if that is just accidental overdoses only, or does that include those that are thought to be suicides?
So we don't necessarily have a breakdown. Most of them, again, I don't have the exact number, but a majority of them would be accidental overdoses. That's a really good question, and I will certainly look into getting that specific breakdown. But I believe that most of them are accidental overdoses. Because again, in the same way that we don't know the exact breakdown of how many folks knowingly were using opiates or fentanyl and how many weren't. But again, since we started looking at the fentanyl laced substances in 2021, most of those are, an unknown use of fentanyl.
Lisa has a comment following what you were talking about earlier. She says, my husband is in advanced cancer treatment and I am watching from his room in Memorial Sloan Kettering Cancer Center. opioids are essential in his pain management as an
Yep.
inpatient and an outpatient. I really appreciate your acknowledgement that fentanyl and its analogs are important for significant pain care, even though the epidemic of overdose is obviously a huge problem.
Thank you for sharing that, and thank you for being here, despite everything that you're going through. But it's important because villainizing substances really just led to increased use when doctors and prescribers started, kind of cutting folks off cold turkey. And, that leads to withdrawal. And, folks who have been taking pain meds for, several years, when they're immediately cut off, there's really no tolerance for pain at all. And again, that withdrawal is far worse than, the worst flu that any of us have experienced. So it is really important that we, challenge that belief that, any substances are good or bad, because that's not what it's about.
Absolutely. And panelists, or I'm sorry, attendees should have the ability to raise their hand if they want to talk. If I did this correctly. I will be honest, Jess, we normally don't do this, but you
Sorry.
encourage no. You know what? This is a good thing because this does help the webinar be more interactive. So if this works, this
Mhm.
is something that we will do moving forward. So
Perfect.
I'm here for it. So if any panelist just wants to take a stab, or I keep saying panelist, if any attendee wants to just take a stab at raising their hand, um, let's just see if this works. Okay, Laura, this works great. So yeah, just raise your hand if you want to talk, just like in school, and we'll go from there. Right.
Thank you. All right, this next section is probably the thing that I'm most excited about when it comes to this training. So I spent, like I said, over a decade working directly in the field and primarily in the substance use realm. And as much as I knew substance use was not about, the choice and, choosing to use despite consequences, I really struggled to kind of communicate that to folks in my life who didn't work alongside me every day. And usually it would just result in a very lengthy soapbox that didn't necessarily get to the heart of the issue, other than to make sure that folks no longer wanted to ask me this again. And so, in the last few years, I've been able to kind of, think about that more because, again, part of this topic is, increasing that awareness and that understanding, and recognizing that all of the folks that I'm speaking to, again, aren't substance use treatment experts and have, like I said, their own experiences, both personal and professional, that understandably have kind of reinforced the stigma that goes along with substance use and addiction. So I really tried to find a way to challenge that in a way that makes sense, that isn't blaming and isn't lecturing. And so what I have found is, that the answer to this really comes down to dopamine. And dopamine is something that we all need in order to survive, right? Right along with water, food, and oxygen. Dopamine, can be equated with motivation. And again, I don't necessarily mean motivation in the extreme form, like getting your PhD or starting your own business, right? I mean, yes, dopamine is involved in those things, but I'm talking about it on a much simpler level. And again, the idea that, we need dopamine in order to get out of bed, in order to shower, in order to, feed ourselves and our family. Dopamine is what we need in order to function each and every day. And so I want to talk a little bit about what dopamine levels look like for, those of us not using substances on an average day. So I will say, kind of before we go into the levels, it's important to note that when I say average, I'm not talking about neurodivergency And when I talk about worst day, I am not talking about any sort of mental health crisis. Again, those are not numbers that I have right away. It's something that I'm actively working on because I would like to be able to incorporate that. But when I say average, it's, on the kind of neurotypical lens without any significant mental health. So, for those of us, again, on a normal day, which I tend to kind of guess is all of us present for this conversation, we experience about 50 nanograms per deciliter of dopamine, again, on that average day. So then I want everybody on here to kind of think about their worst day, right? And like I said, I don't mean a mental health crisis worst day, but I do mean the, incredibly sick and, bank accounts overdrawn and possibly fired from your job. And, there's a significant issue with your child or partner or loved one. One of those days that we often describe as, like the hits just keep coming, right? Where it's one thing after another and, everything feels wrong. So think about your level of motivation from an average day to that worst day, right? How hard is it on that worst day to do anything extra? I often refer to it as like, that's a cereal for dinner type of day, right? Where everything that we, need to do takes all of the energy that we have. And so again, thinking about that difference, the reality is the dopamine for the worst day is 40 nanograms per deciliter. So really recognizing how different your motivation is over just the difference of 10 nanograms, right? And so I want you, again, to kind of keep that in mind as we move on to talking a little bit more about what happens with substances. But so, then we look at the things that raise our dopamine. We look at sex and, that very brief moment of an orgasm brings us up to a 92, right? We get that dopamine burst up to a 92. Favorite food. It's that first bite of food, right? It's never the second or third. It's, the perfect meal that you have been dreaming about and, savoring that first bite brings us up to a 94. So again, that dopamine burst of a 94. And then we look at the best day where we get to have all the sex, all the best food, and we win the lottery. We go up to 100. Okay. So as humans, we are all, chemically designed to experience 40 to 100 nanograms per deciliter of dopamine, again, throughout our lifespan, right? So when we really look at, why folks use substances, and when we really want to challenge those, stigmatizing thoughts, such as, well, if they just loved their kids enough, they would stop. If they just cared about their health enough, they would stop. If they anything would just stop. And the answer to why that doesn't happen is dopamine. So again, like I said, normal range is 40 to 100. And when we look at the addition of alcohol and nicotine, the dopamine burst goes up to 200. And again, we're not talking the entire time of using either of those substances. It's the first inhalation of a cigarette. It's that, first sip of a drink, and then when we look at cocaine, you go up to 350. Cannabis is 650, heroin 975, and meth is 1100, right? And what's even more important to recognize is that not only are these numbers exponentially higher than anyone was ever designed or meant to experience, you also only hit that highest number once, right? So the first line you ever do of cocaine gives you that dopamine burst of 350. But the second line might be at 348, right? And so for those of you who have heard kind of the concept of chasing that first high, that's really what that means, right? Like there is science behind it. And, you are not going to get that high level of dopamine again from that substance. And so when we start to look at why folks use and why folks continue using, this is why, right? It's not about not loving your kid enough. it's truly the science behind the dopamine you receive from cocaine is nothing compared to, going to your child's birthday party. It's not about love. It is truly about the, chemical reward that you have no control over. So again, sorry, I'm trying to like adjust a little bit because I usually have like that kind of open conversation. So any questions or thoughts on this before I move on?
Well, we can have that open conversation
Okay.
if people want to raise their hands.
Thank you.
Again, just like school, raise the hand, we will unmute you. We're glad to do this, and I know it was an unintended experiment here, but I'm glad it's with you here, Jess, because we know that this can work in the future.
Yeah, perfect.
So if you want to raise your hand and talk to Jess, this is the time to do it here before she moves on. Okay, I guess she can carry on.
All right, perfect. So, following the, kind of conversation about dopamine and why folks use despite those consequences, we also want to look at, why folks continue using and why folks return to using, which again is something that tends to have, a huge stigma associated with it, especially when we look at folks coming out of incarceration, out of long hospital stays, which I know that's something that many of you would be, potentially experiencing with your consumers. But that kind of extended hospital stay, pregnancy, all of those things that may, result in that kind of long-term period without use. And so a study was done that really looked at the pleasure center in the brain. So again, that kind of reward cycle that we often talk about when it comes to addiction and, things that give us pleasure. Right. So the study was done, and again, it looked at the three things that we need in order to survive. So, water, food, and dopamine. And so, the first group of folks in studying dehydration, were, hooked up to IV fluid, but for 72 hours did not receive any oral intake of fluids at all. So after 72 hours, they were hooked up to a functioning MRI machine, or an fMRI, which again looks at the different responses within the brain. And, those folks were asked to describe, that first glass of water, describe the condensation and what it will taste like and how good it will feel. Running water was playing for them, but they did not drink any water. They were just asked to kind of use their remaining senses to describe it. And the pleasure center lit up to the equivalent of, the size of a baseball. So again, just in kind of talking and thinking about that drink of water, the response was pretty significant. The same thing was done for folks when it came to starvation. So again, for 72 hours, hooked up to, IV for nutrients, but no oral intake of food. And after that 72 hours, again, hooked up to the same fMRI machine and asked to describe their favorite food. So, the, scent of, that, steak and lobster was wafted in, and they talked about what that first bite would taste like. And the, the pleasure center lit up to the equivalent of a basketball. Right. So again, despite knowing that we need water more than we need food, that pleasure response was much more significant for, the desire for food versus water. And again, you're essentially in that place of survival at that point. And so then the same study in concept was done for folks when it came to substance use. So they looked at folks, for ranging anywhere from 30 days without substance use, all the way up past 2 years. And what they found is the results were exactly the same for 30 days to 2 years. So that desire and that craving was, the same size for those 2 years. After 2 years is when they started to notice a decrease. So again, so folks were, hooked up to the fMRI and simply asked to describe their drug of choice, the process, leading up to using, and what the, feeling of getting high felt like. Again, they did not see their substance, they did not use anything like that. It was just, that kind of verbal explanation. And what was found is that the pleasure center lit up to the equivalent of a baseball diamond. And so again, it's really important to recognize that for 2 years without substances, that response was exactly the same. So for, again, those of you working with folks who do have a history of using and are coming out of a long-term hospital stay, a nursing home facility, a rehab facility, many individuals are going to say like, nope, it's fine. I don't want to use, but really keeping in mind that that response is still going to be there. And therefore, again, having the confidence and the skills to be able to have these conversations, because despite the fact that the craving and the pleasure center response is going to be exactly the same, their tolerance has significantly gone down, right? So that risk of overdose is so much higher for somebody who has had a period without using. And so again, being able to kind of just have these conversations in that very comfortable way, right? We know that lecturing doesn't work. And what's really important is, I know for a long time, we feared that talking about using would make folks use, or that talking about safe using was us condoning use, and none of that is accurate, right? The reality is folks are going to do what they're going to do, right? Nobody needs our permission to do things, right? If us wanting abstinence for people worked, we wouldn't be shifting into a conversation about harm reduction, and we certainly wouldn't be at 107,000 overdose deaths nationally, right? Our desire for abstinence is simply our desire for abstinence, right? It's not a goal that we can put on any of our clients or any of our consumers. Right? When we talk about meeting a client or an individual where they're at, it really is about hearing what they want and being able to, pivot as a result of that, right? Is abstinence the healthier option for most folks? Of course, but it's certainly not the only option, right? And, as we all start to kind of shift our lenses and recognize what harm reduction actually means, we start to be able to look at, okay, how can we hear what this individual is planning to do and go about it in a safer way, right? So that's, again, a big part of kind of what we're here to talk about. So the other piece that's important to discuss is, MOUD, or medications for opioid use disorder. So methadone, buprenorphine, and Suboxone, are the most common ones. And, they are used to treat opioid use disorders. And just as with, addiction and substances, there's a lot of stigma and a lot of myths, surrounding all of these things. Sometimes you're going to hear it's a legal way for folks to get high. It's just substituting one drug for another. It's just us, paying for them to keep using. And the reality is, like, maybe it's a small amount of those things, but in reality, it is simply a medication. It is a tool, and it is used to minimize risk, right? Again, when we are looking at 16 people a day in New York State dying of an overdose, our judgment really needs to step aside, right? And these medications save lives, right? So not only does it treat the opioid use disorder through managing cravings, and increasing dopamine, buprenorphine and Suboxone also, attached to those opioid receptors in the brain and can preemptively prevent an overdose, because they have already attached. There's not a place for that fentanyl to attach to. And so again, it can prevent overdose before it even happens, which is really that kind of two-sided, benefit. And, again, we want to look at why the stigma exists, right? And the reality is the stigma continues to be there simply because the stigma exists around addiction, right? Yes, methadone, buprenorphine, it does not cure addiction, right? But how many medications are out there that don't cure the disease they're used to treat, right? And I'm not trying to kind of go down the rabbit hole of, addiction and diabetes are the same thing. That's not what this conversation is about. But it's about recognizing that, we don't villainize insulin, right? Does insulin cure diabetes? Nope. It is a tool, right? It is a tool that manages, the sugar levels in somebody with diabetes so that they can then make healthier decisions, so that that individual with diabetes is stable enough to be able to make a decision about what they want to eat and what level of exercise they want to engage in, and whether or not they need to, bolus in response to, eating something or not eating something, right? But it doesn't cure diabetes. It is simply a tool that allows the individual to survive and exist at a healthy enough baseline to make decisions, right? When we talk about mental health meds, SSRIs for depression, right? Exactly the same thing. They don't cure depression, but they bring somebody with depression to a baseline to be able to make healthy decisions, right? If anybody on this call has struggled with depression, I'm sure that you will fully agree with me when I say, when you are at that lowest point and one more person tells you to do yoga or deep breathe, you're going to lose your mind, right? Because you're not at a place to be able to implement those tools, right? Somebody with depression needs that medication to be able to bring their serotonin levels to a baseline that they can then implement the tools and try coping skills and make different decisions, right? And again, the medications for substance use are exactly the same thing, right? They are simply a tool, and they're a tool that folks with so many other diseases are, have access to without any concerns. So again, for many of you who may be coming across these medications, with folks that you work with, really just keeping in mind that, there's a lot of myths and a lot of stigma out there. But again, all that medication is a tool. And, again, are there people who might misuse it? Of course. Are there people that might take Suboxone and then continue to use cocaine because Suboxone only works for opiates? Absolutely. But with that Suboxone in the system, it means that even if that cocaine is laced with fentanyl, that risk of overdose is significantly lower. And that's kind of how we want to start to challenge our minds to think a little bit differently. But again, it's not about our goals or the things that we want. It's recognizing how can we support the people that we work with in order to minimize that risk, and live the healthiest life possible. So harm reduction, actually, before I move on, sorry, Blaise and Alex, I'm going to put it back to, is there any questions on any of this before we switch topics just a little bit?
I'm not noticing any open questions in the Q&A.
Perfect. So when we talk about harm reduction, it's a bit of a buzzword right now, but it's important to really look at the fact that harm reduction is far more than, just clean syringes and safe using sites, right? I mean, those things are absolutely imperative parts of harm reduction, but harm reduction is anything that mitigates risk, right? So, seatbelts, bike helmets, vaccines, trainings like this where we get to have these conversations, those are all forms of harm reduction because, again, they're all allowing the ability to minimize potential risks, right? We know that bike helmets don't stop bike accidents. We know that seatbelts don't stop car crashes, right? They instead exist to protect the individual in the event that those things happen, right? And so again, when we talk about harm reduction when it comes to substance use, and really just harm reduction when it comes to people in general, it's just about mitigating the risk, right? So, again, for many of you who come more from that kind of, nursing home and medical field, non-slip socks, right? That's a form of harm reduction. It doesn't stop every single person from falling, right? Or the red socks, right? Where that somebody is in increased fall risk, right? It doesn't prevent falls. It minimizes risk and it helps to alert the staff around that, again, that person is at an increased risk. So again, there are things that many of us practice on a daily basis, and just really kind of looking at redefining what harm reduction means in this context. So I am going to ask that folks raise their hand for this slide, because again, this is really much more beneficial with that conversation piece, because again, I have examples, but I also don't work with the folks that you all work with. And I want to make sure that we, are again, being able to kind of address some of these things in real time. So a big part of what Project COPE is able to do outside of this training is that we are able to provide overdose prevention kits, not only to all of you who attended the training, but to all of your agencies to be able to distribute to clients. Okay. And that means a lot of different things. But it's really important that we, again, look at the importance of everybody having access to this, right? For so long, it was, many of us, whether, intentionally or not, giving resources to folks that we thought needed them, right? And again, as we've seen, everybody is at risk, right? And so, the naloxone and test strips for fentanyl or xylazine, and doTERRA bags, which we'll talk a little bit more about, as well as hygiene supplies and period products and safe sex supplies, right? These are all forms of harm reduction, because when we meet basic needs, we are minimizing risk for those individuals. And so we're able to distribute these, again, to all of your agencies to be able to distribute to all of the clients and families that you work with. And, I want to kind of just gauge a little bit of what everybody's thoughts are about that before we kind of move on to some of those next questions.
Jess, while I'm unmuting Suzanne, who has her hand up.
Mm-hmm.
For people who registered for the webinar, but were not able to attend, now I'm going to send a follow-up email to everyone who registered. So should I encourage people who want these kits to just get in touch with you directly?
Absolutely. Yep. Because we do also have this training that exists online, and we can also have a conversation from there. So absolutely. Everybody is encouraged to reach out to me, and we'll determine the best way to make those connections.
Okay. Fantastic.
So I'm just going to unmute myself. So Jessica, when we were doing these presentations in person, one of the conversations, or actually this conversation happened several times, was transition specialists using these kits as basically a conversation starter. So, you were willing to provide enough of these kits, so we literally could give one to every single person who was leaving the nursing home, and that it sort of took away the stigma of saying, oh, well, I think you have an issue. It's more, it's a very easy thing to say, hey, we're giving one of these bags to everyone.
Yes.
And it's just a conversation starter. And I think that really resonated with a lot of the transition specialists. It was sort of an easy way to open.
Thank you, Suzanne. And absolutely, right? Like the language that we want to use is, this is a bag that we are providing to everyone. And it really is important that you say that phrase to everyone. Because even though you might know you're providing it to everybody, again, we work with clients who have had really difficult experiences, right? And, many of them are looking for that kind of gotcha moment, right? And understandably so. And so if we don't say everyone gets this, the likelihood is that, those folks coming out of long-term stays are going to assume that you see them at risk, or that you're judging them, or that, you've made a decision about them, right? So we really want to say, we're providing this to everybody. And if there's anything in here you don't need, please pass it on, right? Don't ask for them to give it back to you, right? Because again, chances are they're going to be going, okay, well, Suzanne is keeping track of whether or not I give back those fentanyl test strips and the naloxone. So I'm going to just give them back because I don't want her thinking negative of me, right? So instead, just pass it on. Suzanne, go ahead.
I was going to say that I got more than one bag because I went to more than one presentation, and I did exactly that. I kept one or two for myself, but then I did pass on some of the kits because they are useful. They do have things in there that pretty much everyone can use and should have with them, particularly which I had never seen before, the bags where you can dispose of your medications.
Mhm.
We all have,
Yes.
countless, well, I do, jars of medication that just have been sitting in the medicine cabinet, not used.
Mhm.
So for me personally, it was very nice to have some place to just, oh, okay, this is how we can dispose of these.
Yep.
So, and I see other people have their hands raised as well. So I will stop talking and let other people join in.
Alex, are you able to help me with the unmuting of the other raised hand there, please?
I don't see another hand raised at the moment.
Okay. Well, I know Josephine had her hand up for a split second. Okay, now I can unmute you, Josephine. Oh, okay.
Okay, Josephine, go ahead. Apologize for the technical difficulties. We allowed Josephine to talk and then she muted herself. So Josephine, you have to unmute.
How's that?
Perfect.
Perfect.
Hi, Jessica. It's Josephine from the Good Neighbor Program.
Hi.
Hi, I just wanted to say in sort of virtual person, thank you very much for providing the kits to our good neighbors. And even though some of them, it may not be hitting the nail on the head for our good neighbors who are more exposed and available to their local communities, it's a wonderful opportunity for them to have a resource and more edification about what's available out there and the materials that you provided. So I really am very
Wonderful.
appreciative. Thank you.
Absolutely. And so when we talk about these kits, it's the naloxone, it's test strips, and like Suzanne said, the doTERRA bags, which are medication deactivation bags, which again is something, especially for folks coming out of long-term stays, they're going to have medications that at some point they no longer need. And so it is that kind of, low threshold to start these conversations of let's clean out your medicine cabinet together. Or, again, it's activated charcoal. You just add a little bit of warm water and the medication is deactivated and then it zip locks closed so that you can just throw it away in your trash. And I think one of the reasons this is so beneficial is because again, there are other things in place, right? I know many times folks will say, well, there's the drop boxes at the pharmacy or at the police station. I think that's a perfect example of, the phrase great idea, poor execution, right? Because yes, there are these drop boxes available, which is wonderful and definitely better than flushing things down the toilet. But I can say for myself, I had 2 C-sections and a back surgery. And so I had a significant amount of medication in my medicine cabinet. And I had 2 young kids. And I can very honestly say that as a educated middle-class white woman with no legals, I never would have put that much medication in my car with my children and driven anywhere. And so again, recognizing the level of privilege that I have, and I'm still hesitant, let's take a look at many of the clients that we work with. And, those who have had really negative interactions with the legal system, the criminal justice system, and DSS, and again, have every reason to distrust many of the systems. And so again, is that a feasible request? And for many, the answer is no. And then let's forget about the fact that, again, as a working mom with 2 kids, I never even would have remembered to put it in my car, even if I had been comfortable. And then, the other option is always, to dispose of things in wet garbage. And poor Suzanne's so tired of hearing about my dog, but, I have an 80-pound German Shepherd who gets into my trash no matter what I do. Despite a very expensive garbage can, he gets into the garbage, and he actually really loves my used coffee grounds more than anything else. So for me, getting rid of things in my garbage was not an option because, again, that risk of, the dogs getting hurt, was really prevalent. And so again, these doTERRA bags, which actually I do at least have a picture of them, are an amazing way, again, for us, but then also to be able to, educate our clients. And it's so easy, so it's activated charcoal, a little bit of warm water, and the bag actually expands. For both of my kids, it was like a fun science experiment while they got rid of all of the unused medication. And, obviously, we talk about this initially when we talk about controlled substances, but the reality is, any medications that are expired or unused are a risk to somebody, right? Taking a medication that is not meant for you is dangerous. So it's not just about pain pills and benzodiazepines. It's, cholesterol medication. It's Tylenol that's expired. It's stool softener. It's any of these things that exist in our medicine cabinet that we don't necessarily need. So they're dangerous for children, for our pets, for, again, anyone else in the home who does not need and is not supposed to be taking them. So these doTERRA bags are also included, like I said, along with the Narcan and the test strips, as well as hygiene supplies and period products and safe sex supplies. And we also have sunscreen and ponchos for the summer, and wool socks and hats and gloves for the winter months as well.
If that picture is up on the screen, would you mind just describing the picture?
Yep, the doTERRA bag.
Yes, please.
Yep. Absolutely. So the doTERRA bag is the medication deactivation pouch that I was just talking about. So this purple bag right here is, what it is, and then you again put any unused medication in there. So the bags that we provide hold up to 45 pills, and then you add a little bit of warm water in it, and again it deactivates the medication, and then it seals closed, and you can then just throw it away in the trash. And because it's deactivated, it's not a risk to a pet or a child who may get into that trash. So it's really that kind of, double safe option to be able, again, get rid of anything that we don't need.
Gotcha. And I am never tired of hearing about dogs, by the way, as a dog dad of 2, a
Well, I
retired
find that
seeing eye
also
dog and a
once you
current
bring
working one.
dogs into the conversation, everybody listens more. So
Right? I mean, as we should.
So I want to go back to that previous one. And so again, kind of just taking a look at some of these, bullet points on the screen is, a lot of just those kind of conversation starters, but also thoughts for all of you. And I'll kind of jump down to the bottom, but taking a look at, the biases and judgments that, each of you have, right? And again, not in a shaming way, in the fact that we are all people and we all have them. And many times those biases, do exist around substance use, right? And so as we kind of look at the ability to navigate these conversations, are there any biases or concerns that anyone might have, going into these conversations, right? Especially when we are looking at folks coming out of a long-term stay facility where, many of us prioritize, health, right? So we prioritize that idea of health and safety. And how do we, navigate someone who then wants to return to drinking or using? And how do we navigate that in a healthy and non-judgmental way? And something else kind of along those lines is, looking at having a planned response, right? So for many of you who, really have kind of, moved away from these conversations, and again, no fault to anybody. The reality is all of our human service systems have just existed in a silo for so many years. So it really was substance use. Well, then quick, I'm going to pass you over here because we're just here to talk about this. And so, what will it be like for all of you on this call when a client does look at you and honestly say, maybe they're having issues, with their liver and they were just in the hospital, and they're a fall risk, but they tell you, no, I'm planning on drinking when I get out. What is your planned response for that?
Feel free to raise your hands and we will unmute. I mean, I would imagine, Jess, it's one of those things where, is there really a good response to that?
Well, there's a lot of bad ones.
Right. Exactly.
Right. The most positive response is going to be one where, ultimately you start off by thanking that individual for being honest with you, right? Because again, what we want for a client isn't necessarily what they want, right? So when we talk about harm reduction, and when we talk about having these conversations and really practicing anti-stigmatizing language, it's being able to kind of, again, problem solve and pivot, right? And some of these conversations do feel a bit uncomfortable in the beginning, right? Because, I think for many of us, the immediate desired response, right, when a client tells you that they're planning on drinking or using after getting out of, any sort of long-term medical situation, many of us want to kind of shift right into that more of like lecture place, right, where we tell them all of the risks and we remind them all of the ways that, alcohol is going to be dangerous to them and all of the bad things that can happen. But all that does is shut down conversation, right? Newsflash, especially for, this isn't news, right? Especially for any of you who have teenagers, that's the quickest way to lose engagement, right? And now that client, that consumer has gone, okay, well, I'm done being honest, and they're not hearing that, right? So again, instead it's the, thank you for sharing that, and, being able to look at what are the risks, right? Maybe it's sitting down with that, consumer and their doctor to look at the medications that they're on. While we know that most medications do react negatively with alcohol, is there a medication that is less dangerous with alcohol, right? And again, being able to kind of work as that advocate where, again, you're not taking on the role of guiding them through, potential recovery. You're working with them to mitigate that risk and maintain safety. I think in one of the earlier in-person trainings that I had done, with this organization, we talked about, a specific client who had a history of alcohol use, and she would consistently try to drive after drinking. And so we really just as a group brainstormed a lot of possible solutions, right? And none of them were perfect. And I kind of left there wishing that I could invent a lot of things because I wasn't even sure how many of them were available. But, really looking at, support systems and, potentially like a lockbox with a breathalyzer, right? Like maybe car keys go in there and, you can only unlock it when that consumer, uses the breathalyzer. Where again, it's not about the gotcha. It's not about legal repercussions. It's about safety, right? It's, if you're going to drink, okay, but drinking and driving is, one of the riskiest things that you can do. So how can we mitigate that? And different approaches like that, where again, for many of us in that helper role, this does feel a bit uncomfortable at first. But it is the thing that is going to continue to build that rapport. And again, give folks a chance to make healthier decisions, right? So I did speak a little bit about test strips. So again, in all of the overdose prevention kits that we ship out, we have actually both fentanyl and xylazine test strips. And so what these test strips do is you actually put a small amount of the substance that you're going to use, mix in with some water, and the test strip then will tell you whether or not there's fentanyl present or xylazine. And for those of you who have not heard of xylazine, it's actually a horse tranquilizer, and it is being laced into primarily heroin. And the biggest concern about xylazine is that it's not an opiate. And so even though it causes overdose, it's not an opioid overdose, and therefore it's not responsive to Narcan. So that being said, obviously naloxone is still recommended regardless. But it is another, again, a tranquilizer that is, mimicking overdose and is causing death. And the other thing with xylazine is, so we know that for anybody who does use, IV drugs, that the risk of abscess and wounds and things like that. But specifically for xylazine, it's incredibly drying. And so, once there is an open wound, it starts to really, dry and spread. So we actually, because of that, we also include Vaseline in all of the kits that we send out, and that is recommended to be used on the wounds to help keep them moist. And so again, so these strips are included in all of the bags. And again, one more reason why it's important to say, if you don't need something, please just pass it on. Because again, somebody who is using a substance occasionally, truly may not recognize the risk that they're at. So we've talked a lot about stigma, and, in reality, stigma is a set of attitudes, beliefs, and behaviors and structures that lead to prejudice and discrimination against people with mental health diagnoses and people who use substances, as well as other diagnoses that tend to have kind of a negative or judgmental connotation to them, such as HIV or HCV. And so, research shows us that nearly 90% of people with substance use disorders do not receive treatment. And in 2019, only 18% of people with opioid use disorder received medications to treat it. So again, that's looking at the Suboxone or methadone. And while there's a lot of factors involved with that, We know that, the same study shows us that 17% of people with alcohol or other substance use disorders reported that they did not seek out treatment purely because of the concern of how neighbors in the community would view them. So again, that perceived fear of stigma is keeping folks from entering treatment, right? And that's just talking about those who, again, meet that diagnostic criteria. Many of the folks that you're working with don't necessarily meet that criteria, right? But so that stigma is still present. And one of the things that's incredibly important is, how we remove barriers. And I really find that taking the asking part out of it is the best way to remove a barrier, right? Because the act of asking for naloxone or asking for overdose prevention supplies is a barrier within itself, right? Because again, that perceived fear of stigma and judgment, and for many individuals, that is a reality-based fear. And so again, being able to say we are providing this to everybody, no questions, nothing else, just being able to give it is removing a huge part of that barrier. Suzanne, I feel like you're seeing slides you've never seen before. All right, so
I was thinking the same thing.
I was like, this is definitely further than I've ever made it.
To be fair, we gave you 2 hours this time and only an hour before.
So when we, again, talk about stigma, it's important to recognize that the words that we use matter. And for many of you, you are kind of familiar with this concept, right? As we've all tried to change our language of, instead of, a cancer patient, it's a person with cancer, right? Instead of a diabetic, it's a person with diabetes. And so we really want to give that same respect to folks who use substances, right? So the terms that many of us, grew up and entered this field hearing are really very hurtful just by nature of what those words are. And so words like, addict and abuser and junkie, someone who's dirty, we don't want to use that. And while I feel like I shouldn't have to explain it, so it's okay that I do, but someone is not dirty because they use substances, right? They are still a person first. And what's really important to note in this is it is also not our role to correct the language of somebody who does use, right? So if somebody is using and they refer to themselves as an addict or as dirty, we don't correct them. That's not our place. We simply continue to use the more appropriate and anti-stigmatizing language. And that's just our way of letting folks know that we still see them as a person, right? Again, not our place to correct. We just continue to lead through our own examples. And so, it's something that we really see when it comes to urine drug screens, right? For a very long time, it was, whether or not someone's, whether or not the urine is clean or dirty. And so we really don't want to say that anymore. Instead, we look at, if the urine is, positive for a substance or negative for a substance, right? It's again, looking at it as just a tool rather than a judgment of the entire person. And so similar to the idea of, if anybody has noticed, I have said substance use, every time that I say that, and that's because, well, the previous term of substance abuser, really just put, again, that very negative connotation. An abuser is somebody who is physically or emotionally abusive towards somebody. Somebody cannot abuse a substance. They can use a substance. They can even misuse a substance, right? But calling them an abuser is, again, adding that really negative connotation. So we're really trying to challenge that and recognize that it's substance use or substance misuse. Okay. So again, I'm hoping that this might work with some raised hands or the Q&A, but looking at just kind of practicing a little bit of what we're learning. So, revising the sentence to, again, promote anti-stigmatizing language. So Morgan is an addict who has abused oxycodone since she was 12. How might we correct that to, really, practice that person's first language? See,
Laura, you should be good to talk.
Okay, I'm unmuted.
You are good. Yep.
Morgan is a person who has used oxycodone since she was 12 years old.
Perfect. Thank you. Right, and one more. Jeff has been clean for 10 years. Do we have somebody else who can, correct that in a more anti-stigmatizing way?
If not, I have what I think would work. Oh, okay. We have Joyce. I will find you, Joyce, here and allow you to talk. Oh, I had Joyce here.
Joyce, you need to unmute yourself in order to be able to talk.
Joyce, it's showing that you're unmuted here, so feel free to talk. And again, the example Jess said is Jeff has been clean for 10 years. Did I verbatimly get that correct?
You did.
That's because it was 5 words and I could memorize it. Or 6 words.
All right, Joyce, I'll let you off the hook. But, ultimately we'd want to say, Jeff has been substance free for 10 years, or, Jeff has, not used substances for 10 years, right? Where again, it's not about clean or dirty. It's about, the act of not using. And so again, just kind of a quick summary, how does harm reduction apply to your work? So we want to look at deterra bags to, discuss medication safety, medication interactions, test strips, and Narcan, again, available for all, right? In that very universal approach. Safe storage of medication, alcohol, and all substances, right? Talking about the safe storage of medications is another really simple way to start this work. Especially just, that kind of, simple education of, making sure everyone in the home is looking at their medication bottle before taking a pill, right? It's, it's that awareness of what is in your home. Is it locked? Is it stored? Especially now that we're in this realm of, CBD and, cannabis gummies and other things like that, where, where is it stored, right? They look like gummies because they are, but that also means they are something that looks yummy to a child. So how are we kind of, again, working with our clients and the folks that we serve to make sure that these things are stored in a safe way where everyone in the home is able to maintain that sense of safety. Okay. All right, so I've got 2 more that require some unmuting, so I'll just give you a prep time on that. Again, let's meet Sally. Sally works a few part-time jobs and 1 full-time job to support her daughter and is a single parent living with her mother. Sally is presenting with a productive cough that she's had for around 3 weeks. While discussing any current medications, she mentions that she smokes pot to relax on the weekends with friends and sometimes on the weekdays between shifts. She admits to drinking occasionally, but assures you that she substituted it often with small doses of marijuana. how would you make suggestion for best harm reduction practices for Sally in her situation? Anyone would be willing to raise your hand and unmute, that would be great.
To make it easier, I think I might just hit allow to talk for everybody, and that way
That'd be
you can
great.
just unmute yourself. I
Thanks,
think we're
Suzanne.
all grown-ups here. We know how to unmute, so let's go for it that way.
Thank you.
Thanks, Suzanne. That definitely makes things easier, and for, I should say this is Blaze, and for accessibility purposes, when you talk, just say your name.
Hey, this is Laura Bingle. Can you hear me?
Yes, thanks, Laura.
Um, I, I would commend her for working so hard to start with. It's got to be tough. But I would just want to be sure for her, for harm reduction's sake, that she's aware of any policies that her employers might have about substance use, because she
Okay.
risk of losing one of her essential jobs. If they find out she's doing this between shifts, they might send her for a
Mhm.
test, and then, you need to think about those things.
Absolutely. Thanks, Laura. One of the questions I often kind of add to that is inquiring what sort of shift we're talking about, right? Somebody who works in a restaurant versus someone who's a CNA, right? Those kind of expectations are often are very different, right? So let's kind of gather that little bit more information of what sort of shift are we talking about. Any other suggestions?
Hi, this is Mariah.
Hi, Mariah.
How you doing? I feel like coming from a place of just good intention, I would tell her, you don't want to risk losing your job. And maybe during your work hours is not the best time to be partaking in, substances. And everybody's entitled. I know people that have great jobs or stable in life. They drink wine on weekends sometimes. Everybody's entitled to indulge where they see fit, and we're all adults, but at the same time, just letting her know that, I had a therapist once tell me, like, imagine your life is like a table and each leg is a different support. You got your family, you got your job, you got your school, and you have your habits. When you kick one of those legs and something goes wrong, your whole table falls. So I think I would just encourage her to like look at her foundation and just let her know, don't make things too excessive, because you wouldn't want to, risk your part-time, your full-times, and just keep yourself stable. And I would just try to make it incentivizing for her to want to take care of herself and not lose herself, as well as like a harm reduction strategy.
Thanks, Mariah. So I would just kind of, just to kind of give a little feedback to that suggestion. I can hear that it's coming from the right place. And Mariah, I 1000% hear you trying to do it, to kind of say it differently, right? But just for everybody, being mindful that asking questions is likely to elicit a lot more, open dialogue with that client, right? So Mariah, you're absolutely right. When we look at harm reduction, maintaining one's job is really important to harm reduction, right? But again, when we kind of approach it from that way of, telling, and, kind of that like fear-based, oftentimes we're going to lose that connection, right? So a better way to kind of get to that same result would be okay, what type of work do you do, right? And what's going on during your shift that you're feeling that need to to smoke, or that you're struggling with needing to relax, right? So some more of that question versus solution focused, right? Because yes, we're all solution focused. That's why we're all in the helping field, right? But recognizing that constantly giving solutions when someone's not ready can actually come across sometimes as that kind of judgment, even when we don't mean it. And so maybe, eliciting a little bit more conversation about what is going on, what type of stressor you're feeling, what does smoking do for you, right? And starting to kind of look at it that way. Which again, that's why I put these, situations out there and do encourage, everybody to kind of, unmute and talk, because this is going to be a very different approach, right? Most of us have spent, years in the field where it is that very solution focused. We're giving the answers, and that is what our clients need. But really kind of retraining ourselves to ask questions first, rather than just jumping right to that answer. How about the idea of a productive cough, and she smoking pot? What's a potential harm reduction, practice that we could, suggest or discuss?
This is Laura again, and I was getting to that because being totally unbiased and being a nurse by profession, it's like all other things aside, you've had a cough for 3 weeks. Have you seen a medical provider yet to see what's
Yep.
causing the cough? It may
Absolutely.
be related or associated, it might be worsened by the marijuana, but I'm not going to make that judgment. But it could just be, a bronchitis from overwork. So it's like,
Yep.
get that taken care of, because it's going to get worse.
But also the idea of, again, smoking pot is clearly serving a purpose for Sally, right? And recognizing that everything everybody does serves a purpose. And so, again, we are in a very different time where, gummies or oils are again, that kind of potential solution, right? Where, okay, I hear you have a cough, and I hear that, smoking is really helping you to relax. Is there something else you can do while that cough is, healing, or until you see the doctor to find out what's going on, right? And being able to, again, have those conversations, which can feel a little uncomfortable, but that is harm reduction, and that is, best practice, because the reality is us not suggesting or not engaging in these conversations is not going to stop Sally from smoking. Right. In fact, it's much more likely to increase that potential risk. Any other thoughts? Does anyone feel very uncomfortable with this? And again, I ask that honestly, because I'd rather we kind of go over that a little bit now. And again, not to put anybody on the spot, but this is how we do make those changes.
Jess, if I may, I mean,
Yeah.
the other side of this coin too is there are some health benefits to smoking pot or consuming pot in some way, shape, or form, whether it's around pain management or sleep, because there are people like myself who struggle with sleep issues due to the inability to perceive light. So are you suggesting that, asking these questions, could help kind of provide that way of educating people, because we do have such a black and white way of looking at substance use, generally speaking, as a society?
Absolutely. And again, it's us not agreeing with it doesn't make anybody stop. And so recognizing that, smoking is something that Sally has been doing, right? Again, it serves a purpose. It is a tool. While we can, definitely look at other tools, right? The reality is, yoga is not going to give the same immediate response that smoking pot does, right? And so how do we kind of navigate that? But also, Blaze, like you said, that there are other avenues for this as well. And maybe exploring a conversation about medical marijuana, right? Because then there is more control over the supply. There's, less of, you know, a legal risk, you know, kind of, because again, despite what's going on, right, it's still safer to have, you know, something that is more controlled versus, you know, something that's, you know, on the black market or whatnot. But us being able to talk about this in that really comfortable way is again going to make, you know, the folks that we serve much more comfortable to, you know, engage in that suggestion and maybe, you know, explain why, you know, medical marijuana is not an option because it's so expensive. And, you know, so this is what I do and this is why. Okay, so let's continue to talk about, you know, the safest way to, you know, continue to do that. All right, I've got one more case to go over. So we'll meet Carl now. Carl presents with post-operative knee pain and would like to refill his prescription. He's been in physical therapy for 6 weeks and has been prescribed oral opioids to manage his pain. Carl admits that he's not trying to take his medications as much and that the pain has decreased, but has not returned to work since the pain is not going away. You discover that his wife has leftover pain medications from a previous dental procedure, and Carl describes his wife as being pain-free after taking those medications. How would you make suggestions for best harm reduction practices for Carl? So kind of same format as last time, you know, please unmute yourself and give, you know, any thoughts or suggestions. So what are some of the risks that we see here with Carl? Are knee surgery and dental surgery the same thing? So we might want to begin with that conversation, you know, looking a little bit more at the long-term reality, right? Again, I mean, not knowing much more than what's in front of us, right? But typically a dental procedure is a, you know, much more clear-cut situation, right? Where there's, you know, a start, a procedure, an end, some pain management, and then, you know, typically that pain is gone, just by the nature of how, you know, the surgery and the procedure is, versus when we talk about knee pain or knee surgery, you know, and especially a knee replacement, that likelihood of ongoing pain is far more likely, right? And so again, we want to kind of look at, you know, those situations and make sure that Carl is aware of, you know, his long-term prognosis, right? As well as, you know, okay, Carl's wife has medications now in the house. Is there anything we talked about on this training session that might assist us with that? Those helpful doTERRA bags might be a good option, right? Because again, as long as, you know, with his wife's consent to, you know, dispose of that unused medication, it's then taking the temptation away for Carl to begin misusing, again, a medication that is not prescribed for him and could be far more potent than the one that he is taking and, you know, lead to that, you know, increased risk. As well as, you know, opioid overdose can occur just by taking too many pain pills as well. It's not just because fentanyl is laced, right? It's, in combination with additional opioids or with, benzodiazepines. So other medications, increase that risk of an overdose as well. And so, if Carl's wife is on board, we're kind of seeing how he's starting to see, wait a minute, her meds must work better than mine. Maybe removing those medications safely from the house, is that way to, again, practice harm reduction right away. And then potentially, sitting with him and contacting his physical therapist or his doctor, and, let's talk about what this continued pain really feels like and what is, typical versus what is concerning. And, working as that advocate alongside him, to help to kind of, see other options. All right, so what I am going to do now, I'm just going to change the screen that I'm sharing, because I do want to, kind of finish things up by showing all of you our overdose prevention video. So on all of the overdose prevention kits or the naloxone kits that, we're able to send out, there's a QR code that goes straight to our website, which has a less than 5-minute video that demonstrates how to recognize an overdose and how to respond to it using naloxone. And this is really important because it kind of furthering that idea that I'm not asking anybody to become experts in this field. The onus is not on any of you to train your clients or your consumers in how to use naloxone. Right? That information is readily available for them. It's something you can certainly do with them, but it's also something that you can simply let them know and they're able to view it on their own. And this video is available both in English and Spanish. And I'm going to make sure that the closed captioning is on as well. So give me just a moment and I will get that pulled up for everyone.
All right, and while Jess is pulling up the video, this is Blaze again here. We will have about 20 minutes for thoughts and discussions after the video plays here, and the website for OASAS is oasas.ny.gov, and my JAWS screen reader just said that the screen changed. So
Perfect.
Hit the video whenever you're ready. You might need to share the sound.
We're in the midst of an overdose crisis. The COVID-19 pandemic and illicitly manufactured fentanyl in the supply chain have worsened the crisis and led to more than a 40% increase in opioid overdose deaths across New York State from 2019 to 2020. If you use substances, you're at risk of an overdose. Stay safe by using fentanyl test strips, carrying naloxone, and avoid using alone. Naloxone is a nasal spray that rapidly reverses opioid overdose with a success rate of 83 to 100%. If you're in a situation where someone may have overdosed, follow anchor steps. Assess, naloxone, call 911, have additional naloxone ready, observe and perform rescue breathing, review and monitor. Assess. Common signs of an opioid overdose are unconsciousness or unresponsiveness, slow or weak breathing, small pinpoint pupils, bluish lips and/or nails, gurgling or snoring sounds. If someone shows signs of an overdose, try to wake them up. Yell their name or "I'm going to call 911." Make a fist and rub your knuckles firmly along the middle of their chest. If the person is still unresponsive, administer naloxone. Even if you're not sure that they've taken opioids, no harmful effects will occur if you administer naloxone to someone not experiencing an overdose. Naloxone. Lay the person on their back if possible. Peel back the naloxone packaging to open. Place the device with your thumb on the plunger and fingers on either side of the nozzle. Tilt the person's head back and provide support under their neck. Place the device in one nostril until your fingers touch the bottom of their nose. Press the plunger firmly to give the person the full dose. Once you've administered the naloxone, call 911 for additional medical support. You do not need to mention the person has overdosed. Have extra naloxone ready. Additional doses may be given every 2 to 3 minutes in alternate nostrils until they respond or until emergency help arrives. Observe. If you feel comfortable, provide rescue breathing, or if trained, CPR. Use gloves and a breathing barrier if you have them available. Review and monitor. Lay the person on their side with their hand under their head to prevent choking. Try to keep them awake and breathing. New York State's Good Samaritan law protects the 911 caller regardless of age and the person experiencing an overdose from being arrested in many situations. Check your state's specifications to see how you are covered. Get free naloxone through opioid overdose prevention programs or obtain naloxone from your local pharmacy. If you use substances, visit nextdistro.org to see how you can get a kit shipped to your home. If you or someone you care about is in crisis or needs help with substances, alcohol, or gambling, call 1-877-8-HOPE-NY or text HOPE-NY. The Hope Line runs 24/7, is toll-free, and confidential.
And for anyone who needs the numbers from that for the Hope NY, it is 467-369. So 467-369 for Hope NY.
So that kind of concludes everything that I had to go over. I can send out to Blaze the order form for any agencies that are looking to again request, naloxone, doTERRA bags, and the other hygiene items to be able to distribute to consumers. But please, any questions, any concerns with all of this, please let me know.
And we have 18 minutes for questions, comments, and such. Jess, either you can send me the form or people can just get in touch directly,
perfect.
whatever, however, I will defer to you on that.
I can send it to you if you want to just email out. The only other question I also have is, would I be able to get email addresses for everybody who attended?
Yes.
Okay, perfect.
Yes, I will. I'll generate a registration report and get that
great.
to you.
So my last little thing before I promise I will let everybody ask questions if you have any. So because we are a grant program, we rely on evaluations. So shortly after this, within the next day or so, our evaluation team will reach out to everybody, with an evaluation. Would really, really appreciate everybody complete. And again, just please be honest, because we've made changes based on, the feedback that we receive. And it just helps a lot in, proving the work that we're doing, for the next couple of years.
All right, if we don't have any questions, Jessica, I'll just say thank you so much for doing this presentation. We offered this as a webinar because we had such a great response when you came in person. And I have heard since people talking about having these conversations and really sort of reconceptualizing what we're doing in this harm reduction model. So It's definitely well
That's great
received.
to hear.
Something we were missing and looking for. So we really appreciate all the time that you spent with us.
Absolutely. I will just share my screen real quick just to put up my email address so that if anybody wants to reach out, that will be up on the screen as well. And again, I'm Jess Sorbello. My colleague is Katie. So both are still up here, but would definitely encourage you to just email me with any questions. And again, even if it's after this is over and you're kind of thinking about a specific case or a specific situation, please just reach out and I'm happy to kind of, talk things out in any way.
All right, and I'll just read out the email for you. It's Jessica, Jessica .Sorbello, SORBELLO at OASAS, which is OASAS.ny.gov.
Thanks, Suzanne. And thank you so much, everybody. I really appreciate it.
Yes, thank you so much. Before you go, quick reminder that there is a survey at the end of this webinar to help me, Blaise Bryant, come up with future webinar topics, because the reality is this webinar series, it doesn't happen without you. So feel free to take that, or I will also include that in the follow-up email along with Jess's contact info and the order form for kits. Our next webinar is on September 11th with the Office of New Americans. So stay tuned for more info on that. And since we do not have any more questions. Oh, you're very welcome. All right, you all are very welcome and have a great rest of the day.
Thanks so much.